Welcome to the Skin Trust Explainer. Today, we're going to definitively answer a question that honestly causes a whole lot of anxiety for patients. Exactly when should you, and just as importantly, when shouldn't you, get a second opinion on your skin pathology? Now, I know it's a topic that can feel pretty overwhelming when you're in the thick of it, but by the end of our time together, you're going to have a crystal clear, practical framework for making this exact decision. But real quick, before we jump into the details, let's cover our source material. The evidence we're looking at today is current as of July 11, 2026. It's been reviewed by Dr. Thomas Hocker of SkinTrust.com. He's a triple board certified dermatologist, a Mohs surgeon, which if you don't know is a highly specialized tissue-sparing surgery for skin cancer, as well as a dermatopathologist, author, and educator. And please remember, this explainer is strictly for general education, so it's not individual medical advice.
All right, so here it is, the absolute most urgent question on a patient's mind right after a biopsy. You get that phone call, you hear a diagnosis, and literally the very next second you're wondering, wait, should I get someone else to look at this? It is a totally natural instinct to want 100% certainty when it comes to your health. So let's get right to the definitive answer.
Well, to cut right to the chase, the direct answer is that most routine skin biopsy diagnoses actually do not need a second opinion. I know that might sound a little surprising, right? But the data backs it up. In blinded reviews of routine specimens, general pathologists and dermatopathologists agreed over 93% of the time. The vast majority of everyday skin biopsies are totally straightforward. So routinely asking for a second set of eyes on a really common, clear diagnosis, it's usually just low yield and unnecessary.
However, and this is a big however, that rule definitely changes under some very specific conditions. Expert review really only becomes valuable when the diagnosis is uncertain, if it's extremely rare, if it completely clashes with what your doctor saw in your physical exam, or if it could significantly alter your surgery, your cancer staging, or your follow-up care. Basically, we want to save the heavy lifting for the truly difficult cases, the ones that live on that blurry clinical boundary. To really grasp why a second opinion works in some cases, but maybe doesn't in others, we have to look at two totally different types of medical uncertainty. The first one is called interpretation uncertainty. That's essentially the difficulty of reading the tissue that is physically sitting right there on the glass slide. But the second type is sampling uncertainty, which actually means the biopsy might have just completely missed the most relevant part of the lesion altogether.
Think of it like this, because I love this metaphor. It's exactly like taking a photograph. Rereading a photograph can perfectly clarify what is already visible inside the frame, right? If something is a little blurry, a better expert might be able to figure it out for you. But no matter how good that expert is, they literally cannot show you what was happening outside the frame when the picture was taken.
And that brings us to a super crucial point about sampling uncertainty. Another reader cannot magically see tissue that was never actually sampled in the first place. For instance, if you only have a very superficial surface biopsy of a deep tumor, a new pathologist won't have a clue how deep it actually goes. The real answer in those kinds of cases might require cutting much deeper sections from the original tissue block, or honestly, it might just require an entirely new biopsy.
So what are the actual clues that you might be dealing with interpretation uncertainty? Well, look for specific trigger phrases right on your pathology report. If your report uses genuinely uncertain language, things like favor, cannot exclude, suspicious for malignancy, or atypical melanocytic proliferation, that should immediately trigger a conversation with your doctor. And look, the goal here isn't to panic. The goal is to ask what exactly remains unresolved, and more importantly, what medical decision is hanging in the balance.
Now, let's shift focus to see how this builds on your physical exam. You absolutely need a review when the microscope's close-up view just doesn't match the clinical landscape. In medicine, we call this a discordant diagnosis. So, if a spot on your skin looks incredibly aggressive and highly concerning to your dermatologist, but the lab report comes back saying it's totally harmless, that mismatch really matters. The microscope and the naked eye ultimately need to make sense together.
Getting a review is also a highly reasonable move for what we call intermediate melanocytic lesions. And hey, this isn't about bad pathologists making mistakes. This is just about complex biology. These specific lesions exist in a very well-documented gray zone where the physical features of benign moles and dangerous melanomas heavily overlap. Because of this, two highly qualified experts might classify the exact same slide differently. If your diagnosis lives in this gray zone, a second look is a very smart play.
Rare tumors are another major area that benefits massively from expert review. Get this, in one French network evaluating over 2,500 rare suspected skin adnexal carcinomas, which are these very uncommon tumors of the sweat glands and hair follicles, expert review changed the diagnosis 21.3% of the time. Over 1 in 5.
Because these are seen so rarely in a normal clinic, an expert who focuses on them all day long adds tremendous value. But you might be asking, what did that 21.3% actually mean for those patients? Well, most importantly, 5% of those rare tumor cases actually cross the critical, life-altering boundary between benign and malignant. That is a massive distinction. We are talking about 1 in 20 patients having their entire treatment path completely altered just by getting a second set of expert eyes on the slide.
Which leads us to the absolute highest priority for a second opinion, right before an irreversible step. If a revised diagnosis would change whether you end up having Mohs surgery, a standard wide excision, radiation therapy, or maybe no surgery at all, you absolutely want to get that second opinion before any procedure begins. Simply put, the value of clinical certainty rises directly with the consequence of the decision.
To really highlight this, let's look at a highly selected UCSF cohort of 358 difficult malignant referrals. In this group, expert review changed the actual surgical management in 8.9% of cases. Now keep in mind, these were cases chosen specifically because they were ambiguous or difficult, so this isn't the error rate for all everyday biopsies. But still, for the tough ones, almost 1 in 11 patients had their actual surgery plan changed by a second look.
And honestly, this next part blows my mind. Out of the 32 total management changes in that study, 28 of them were outright cancellations of planned surgery. This brilliantly illustrates that a second opinion doesn't just mean finding something worse or more scary. Very often, it actually prevents an operation that the revised, more accurate diagnosis proves you no longer even need.
Let's flip the script for a second, though. We have to balance all of this out. Additional review usually adds absolutely nothing and honestly only delays your care. If the diagnosis is common, the wording on the report is completely confident, the finding fits your clinical picture perfectly, and a new reading wouldn't change your treatment plan anyway. If you have a classic, straightforward cyst, shipping your slides across the country is just going to add noise, cost, and anxiety for no real benefit.
So, as a practical way to summarize all this, it really comes down to mapping your exact situation directly to the most logical next step. If it's common and clear, just proceed. If it's an ambiguous melanocytic lesion, consider an expert review. If the pathology report completely contradicts what the spot looks like, reconcile that with your doctor. It is all about matching your specific level of uncertainty with the exact right clinical tool.
This crucial point is captured just perfectly in Dr. Hocker's primary rule. It reminds us that the true purpose of a second opinion isn't to take a poll, collect votes, or just magically make yourself feel safer. It is used exclusively to improve the clinical decision. You order it when the uncertainty and the upcoming medical decision are large enough that another expert's view could actually change the plan.
Also, keep this in mind. If 3 different pathologists have already given you 3 different labels, getting a 4th label might not help you at all. Sometimes you need a completely different remedy. If the biopsy was too superficial, you don't need a new reader, you need a repeat biopsy. If the tissue is unreadable, you might just need deeper levels cut from the block. Always identify the real problem before you go seeking the solution. Now, when you do decide to pull the trigger on a review, it is vital to equip the consultant properly. Ensure they receive the exact biopsy site, any clinical photographs, and most importantly, the specific decision-oriented clinical question. Don't just send it and ask, "Hey, do you agree?" Ask, "Is this invasive and does it change my surgical margins?" Because in pathology, context is literally everything.
And you should definitely be prepared for the fact that the reviewer might not just give a simple agree or disagree. They might refine a very specific subtype, they might recommend a specialized molecular test, or they might honestly conclude that the existing biopsy is physically insufficient and more tissue is needed. Remember, a recommendation for a new biopsy isn't a failure of the review process, it's just a recognition of physical reality.
So for your absolute next step, ask your treating dermatologist this one decisive question. Would another interpretation actually change what you recommend? If their answer to that is yes, then a review should absolutely occur before any irreversible decisions are made. It really cuts through all the noise and focuses strictly on the action you need to take.
Remember, while a second opinion can't make ambiguous biology perfectly clear or completely erase the gray zones of medicine, it empowers you and your clinician to craft a treatment plan that is transparent, logical, and most importantly, safe, under whatever remaining uncertainty exists. It's all about managing your risk intelligently. Dr. Hocker created Skin Trust to provide free, evidence-based dermatology education and help patients and clinicians make clearer decisions together. We hope this explainer has given you the confidence and the framework to know exactly when to ask for a second look at your skin pathology. So, looking at your own health journey right now, what major decision might benefit from a more focused question today? Thanks so much for joining us on this explainer, and stay curious.